Really appreciate everyone being here. I'm Ness Avenue. I'm a community equity lead at the Office of Equity for the San Francisco Department of Public Health. And I just want to just take the moment and say how much we really do appreciate you all coming out today. It means a lot to us at DPH to be able to get to the point where we're shifting and making sure that we really do what we can to help support our communities the best way that we can. And we are aware that a lot goes on in everyone's lives and the incredible work that y'all are doing. And the fact that you're taking the time today to be here with us, we're just really grateful for that. I just want to thank you so much for being here today. So this is the agenda for today. I did a welcome meeting. We're gonna do a land acknowledgement, talk about the purpose, DPH vision and priorities, budget overview, approach to reductions, timelines, feedback, and questions. So this is the agenda today. And we really do also make sure that it's interactive, that you feel free to be able to ask questions, clarification, or anything when our incredible director then speak, because we really do want to hear from you as well. So really, please keep that in mind and take that in. And also, we found that it's actually good to record a meeting so we can remember and capture everything, even though we do that, people taking notes. So we just want to let folks be aware that we are recording. All right, this is our land acknowledgement. The San Francisco Health Commission, San Francisco Department of Public Health staff acknowledges that we are on the unceded ancestral homeland of Ramaytush Kalani, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Kalani have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respect by acknowledging the ancestors, elders, and relatives of Ramaytush Kalani community and by affirming their sovereign rights as First People. So that's our acknowledgement. And I just want to just, I always appreciate the fact that we do this acknowledgement. And it's also quite for us to make sure that we do something throughout the year, right? And to really acknowledge, where we are, where we're self-seeing that, right? And aspect of it. That's the next one. Yeah, it doesn't come down yet. Hold on 1 second. All right, so I just wanted to also take a moment to thank DPH and its staff who helped put this together. Took a collaborative effort of many departments to be able to do this. I know when people think of DPH, sometimes you think about the branch that you actually work with, but we actually are a entity, and a lot of us came together to be able to be part of this and to be able to put this in. So I just want to say thank you all who were part of that staff, and we really greatly appreciate that. So just a couple of things, house rules that we ask folks to keep in mind. Please help us continue to have a respectful, solution-focused space. Because it's important for us to make sure that everyone is heard. We recognize and we understand that people may have different experiences, different thoughts and stuff, right, aspect of it. And please try to remember to do it as much as we possibly can in a respectful manner regarding that aspect of it. There will be a Q&A portion of this. And so we will have people running around with mics. So we just ask when you're ready to speak, whichever we do encourage people to be able to participate and to ask any questions that you have, just to raise your hand and someone with the mic will be able to come in regarding that aspect of it. Just the final thing before I turn it over to Director Dan is just remember this is an opportunity for each and every one of us to be able to have thoughtful conversations today and this evening. And once again, we're grateful that you are here. We're very grateful that Director Dan is here to be able to speak. I do that.
Thanks, Vincent. Okay. The next couple mentioned it, we did one of these yesterday in Bayview. What we had was great. I think we had 2 CBOs in the room with us, like 25 DPH staff, we had 75 folks participating virtually. We're doing this one today. I hope to do many more of these, every one of our CBOs. If the CBOs contract to us, my understanding is folks got this email. And we really want to go through both sense of collaboratively how we are outlining priorities for the department. And then what is very salient to many folks, we're jumping into budget, it's difficult budget decisions we have to make. We want to engage with folks, we want to be in a room with folks collaboratively, even when we have difficult decisions to make. So I hope everyone can try to join these, weigh in. This is a chance to actually be in dialogue together, and we're still figuring out as a department how we do more of these, but I want us to be engaging in this way, very, very frequently together. So I'm gonna try to hit a few things, and then we'll just talk about. First thing I'll do is just go through a draft of how we're outlining in the department some of our big goals. So you have a sense of that. We've gotten many questions. Like, what is the department trying to prioritize? This is not exhaustive or exclusive, but it gives you a sense of how we're describing that. The vision up here, I keep saying, is a very inspiring vision to me about San Francisco being the healthiest place on earth. And we really have tried to pull for all people for obvious reasons, as we really dive into quite a bit of health disparities and mortality, a full range of things. And so 3 big goals we have. One is the boldest and most difficult and longest term one, which is how do we get to 0 or eliminate, eradicate a set of health disparities. We have very big disparities on premature deaths and mortality, also on the beginning of the lifespan, on premature births, there's a whole range of other things we can pick. But we really want to hone in on some of those things. And together see, including going very far upstream, think about how over the course of 10 to 20 years, we actually close some of those disparities. And to do it in a very data-driven way as well, in a community-based way. Data-driven being, we're a relatively small city, so when we look at some of these disparities, we can quantify the number of, say, Black African Americans that are dying of cardiovascular disease above the general population average. Like, that is a very quantifiable number. Same on preterm birth, when we're looking at one zip code, it's like 12 babies born preterm in a particular zip code accounts for that disparity. So it starts to make it more concrete what we're all wanting to do, and actually finding a way to engage with the community, not just our healthcare community, but others across the neighborhoods, to figure out how we, and not just the department, but others, really make the right investments. How do we look at the current investments we're making and say, if we're actually making a difference on things to close those gaps over time. I think our team is very excited about this, but I think even as we start to debate this, it's the biggest, most difficult one on the page here. But it is a thing that we have a lot of appetite to do more of. In recognize we do a ton of stuff here in San Francisco around this. The second is being the best healthcare delivery system in the world. And delivery system involves the traditional physical healthcare health system, as well as so many other things. And they're key components of access, and how do we really think in a more outcomes-driven way about what's happening, and also how do we think about care in a more integrated way. By integrated, I mean we provide great care when someone is in front of us, and we lose folks in between often. So those are some of the things. Number 2 and 3 is tackling together with many folks in the community that we have a health homelessness crisis. And there's a lot for how we will do this. One of the things I said yesterday that I think resonated, because we often hear from CBOs on this, is how difficult it is to contract with DPH and how difficult it is to get paid in a timely way around that. I think we not only recognize that, but internally that takes a tremendous amount of our team resources as well. As our team resources that can be spent working on programmatic things. I think we all share a desire, for example, to to fundamentally improve some of those pieces. So this is high level, you all should weigh in this on the short one. Let's just advance so we can hit a few things. Now, we're talking budget here today because we are entering budget season. And there are a lot of budget pressures, and we will talk about a $17 million CEO reduction that some of you may recall in this past budget cycle we had to commit to for July 1 start. Go back through that in a sec, but a little bit of context of the DPH budget that I think is important. Any of the reductions we're talking about, we are talking about in the context of DPH continuing to grow. Under no circumstances here are we talking about DPH shrinking. The main issue is how we match our revenue and growth. We have been over the past, I think since 2019, our average annual growth rate has been about 5.5%. Over that same period of time, city revenue has grown by 3.3%. And so that leads to a range of challenges for how we try to manage that. And we were going to have massive Medicaid cuts and other safety net cuts coming out from the federal bill. And it's going to require us really doing everything possible to manage the overall growth of the program, just to be more in line with city revenue growth. And so that's the context. And I also know for CBOs, I mean, a big portion of our growth is also labor costs for civil service. Say that in affirmation for staff. It's just factually speaking, and I know CBOs often raise a range of dynamics around that, and that's a thing I acknowledge and note. And also as the city, like that happens. And so that's awareness for kind of things that just go into roughly the 5.5% growth rate that we have. So that's been about $1 million growth at DPH over the past 6 years. Next page. And so, yeah, between 2019 and this current budget year, our budget has grown from 2.5 to 3.5 billion. The local share, because we have also done our best to go get more federal revenue reimbursement, has grown at 4.2%. So we have offset some of that growth by just getting more Medi-Cal reimbursement, for example. And over that same period, this is the citywide general fund growth. And there are more numbers of how this looks like on an annual basis going forward. This current year, our local budget is growing a lot at 7.1%. We were able to decrease that over the past 2 years with just a lot of revenue of going after Medicaid reimbursement, but we are tapping out on that. And so our growth on a net basis, meaning local general fund dollars that we use, is increasing by 7.1% this coming year. Fast forward, and I think folks know we need to have much more discussion in separate forums also about the federal and state cuts, both for the folks with the range of immigration status that we're very concerned about and are working through plans for coverage around, but also the several $100 million of annual cuts we expect to Medicaid on DPH reimbursement based on the federal bill that's been signed. So more to come on that, which involves engaging with their CBOs to actually help reach the community and keep people covered to the greatest extent possible. But I think folks are aware there's some very, very terrible pressures coming soon. And then part of why we want to start engaging now is thinking about the budget. And so again, I'll mention the $17 million in settings. Pretty, but for this past budget cycle, which I guess here, I now know here in San Francisco, we do it on 2-year cycles. We did a lot to try to solve our budget through getting more revenue, preserving services to the greatest extent possible, and preserving city staffing, requiring our staff, even as we eliminated a ton of vacancies and repurposed and moved around some staff. I'm saying this so you understand we are trying to do our part as well around that. The total revenue we have committed to, of which there are a lot of initiatives over 2 years, is over $550 million. That's part of how we had that overall DPH growth exceed the local revenue growth. And these are the team trying to find additional creative things to build Medi-Cal for stuff that we currently don't build for today, but we need to in this world, because every dollar we draw in from health plan reimbursement, Medicaid, is a dollar we can save in general fund dollars for maintaining services to folks otherwise through a range of programs that we have. Here's the next page, just want to note. Who is familiar with, folks remembering the $17 million number? Okay, yes, so when we talked about the budget this last time, we're in current fiscal year where we identified a range of efficiencies and cuts that we had to manage our growth. What we also said is for year 2 of the budget cycle, so starting July 1 this coming year, in order to solve balance our budget, we had to commit to another $17 million in CBO reductions. The reason why we did that, they're unallocated, meaning we do not know how to get those, is because we did not want to have to rush this past spring over the course of 3 to 4 weeks without being able to engage with folks in coming up with $17 million. And so our goal is to start a process over the next several months, where by early next calendar year, 2026, we have clarified together how which programs we are going to have to reduce to hit that $17 million target. I'm not saying anyone's going to be happy about that $17 million, but it's important for us to actually be able to engage with our community, and that's why we want to have these sessions. We want to invite folks. We want tell your colleagues to show up. We have a process. We want to be able to hear and debate some of these things as a community together. And so that's the 17 million, and the goal is to have notice of that by early calendar year 26 in advance of July 1. The reason this process is also important is to be frank, I expect when, in December or so, we get the mayor's office budget instruction from the mayor's office. I expect in a range of budget situations, we will all be asked for additional cuts we have to put up. Having this structured discussion process allows us to have in that discussion much more versus sometimes like in 2 days when we have to identify a set of cuts, like it is just a random grab bag at that point. It's much less thoughtful. And so let's go forward to the next page. No decisions have been made. We do not have a cheat sheet, I promise you, anywhere. Anything that totals $17 million. Our team has even been debating how to look at all of our studio contracts in a more structured way. We have hundreds and hundreds of contracts, over hundreds and hundreds of millions of dollars. Vincent mentioned the department is very disparate. We are trying to have an integrated view, even building that view, having all of the contracts in one place so we know the total now, what they're for, has been a more difficult task than you would imagine. I think that is good in preparation for the sort of things that we need to do. And we are engaging early and having these discussions without a hypothesis yet of how to get to the 17 million. And I say that for real, like there's no we are hoping you will help us figure out how to make some of these difficult decisions. I want to be very transparent. I do want to note, we have had a lot of discussion and thinking about how to do this in an equity-centered way because for a few reasons. One, the types of things that are going to be lead to a higher. There are a bunch of services that are Medi-Cal funded, where either all of the costs of Medi-Cal rated first with no general fund, or 50-60% of it. So those programs, when we cut them, we only get 50 cents. For every dollar we cut, we only get 50 cents of general fund or 40 cents back from the general fund piece. The 17 million is general fund dollars we have to solve for. So if we went purely based on that, we would end up cutting disproportionately kind of upstream preventative health, community health, a lot of things that are not Medicaid reimbursable. And that is something we need to be aware of because we do we want to keep drawing in federal revenue. But I think our team is quite conscious of making sure we are thoughtfully approaching the whole picture and also, big CBOs, small CBOs, congruent, partner community, all of those things need to factor in, which makes the picture very complex to think about. Hence, we are basically saying we need you all, we would like you all, I'm sure you will have thoughts and some people will agree with, some people won't. To invite you into this very challenging decision-making process that people have, which is, Jenny's been around for a little bit while. Some of the difficult set of budget decisions we've had in recent memory. Since 2008 or 9, according to Jennifer. Okay. So, one last thing I think I'm going
sorry.
Here are some of the things that we've asked our team, the subject matter experts, to start to look at with respect to the CEO contracts and programs that they manage. And we want feedback and thoughts on it. So how aligned are those programs to the core strategic mission and goals of the department? What is the impact on equity and reaching a range of communities that may be underserved or not sufficiently reached or served for a range of other things happening in the world? Cost efficiency, revenue potential, performance, outcomes for this contract. And some of these things, as our teams look, we have no data. We have no outcomes data for contracts. We don't even have quantitative data on fully the amounts of utilization. Those are things that you should expect in any world we're trying to partner on to sharpen, because we need to have more of a structure around that. And some things we do have a good sense of revenue or outcomes and performance. Those are just helpful factories to have for us. Okay, I think with that, I think we can probably pause. And I think it's the goal of this discussion is number one, we need feedback and thoughts on the overall direction where DPH is trying to collaboratively go. And number two, most saliently to you all, because these are CBO engagement discussions, and the invite list of folks that have a contract with DPH, of which we are kind of in this mix of having to make hard decisions around advice on how you think we should be thinking about going through the hundreds of contracts, hundreds of millions of dollars, the type of criteria we see. So this is the opener of discussion. All right. So who's facilitating?
I am.
Vincent. Oh. And yeah, I think I kind of said most of this. Thank you.
Thank you, President. We really appreciate you taking the time and give the update. So we actually are right now going to go into the Q&A piece, and as we expressing, we really do want to hear your feedback. So any questions or clarification that you may have, please do it. We also ask folks just a reminder, just be respectful, and also just be mindful of trying to ask the questions that we clarify within a minute or so, because we really do want to have a space for the here as the meeting voices that we have in here, because it's such an amazing, diverse, and different perspective here, and it's important for us to hear everyone voice as much as possible as we can. So as you just be mindful that you do ask the questions or any clarification. So with that, we're opening it up.
Right here.
Thanks. That's it.
Hi, my name is Sally Chen. I'm the Deputy Director at Livable City. We provide Sunday Streets, the Open Streets program in San Francisco. My first question is really a nuts and bolts one, just around the process and who the decision makers will be and when those decisions will happen. So for example, it sounds like staff will do evaluation. Will this then go to the commission or the board of supervisors? And who are the other decision makers that will be a part of this process, and when will they be involved?
So I'll answer it briefly and see if Jenny or anyone will jump in. I mean, the whole DPH team will be, and the entire executive team is going to be reviewing all of these things. We're trying to ask and create a process and space for our team members or the subject matter experts of their domains to be able to kind of help debate and think through these. And 17 million itself is built into the budget. We give routine updates at our health commission, and so both their respective budgets, what we're doing. So all of these things we anticipate giving pretty clear updates on. In any case, though, part of what we're committing to is by the beginning of the year, we want everybody to be aware of what we've landed around this. So there's plenty of time for planning in advance of July when it goes to the next fiscal year. Anything else you want to add? Okay.
Hi, my name is Eric Green-Frost, gender perennial pronouns. I'm the Executive Director of Senior Disability Action. Mine's a question / suggestion. You had mentioned about being data-driven, which I love. And I'm curious about what ways, if any, that data could be public or at least related to us. I know we have that COVID dashboard that's beautiful. I ask specifically because I think, if we see reduction in funds, having access to data to help us, apply for other grants would be really useful. But I also just think for all of us to be able to know what is the data out there, especially in trying to close some of these equity gaps. What do you think would be able to be released?
I mean, any data we have, we will release as much as possible. We've been having Susan Phil is the lead for population health department. Division, we've been starting to debate, anything you want to add, Susan?
Yeah, I think that's a great question. That is definitely our goal. Like right now, we are in the process of our community health assessment and community health improvement project, which on the chip. That will be some data that will be available sooner rather than later, but we definitely have plans to improve and expand the amount of data we have for other partners in our communities.
And I think for us, we've been debating, can we get that, can we drill down on some of these things to a zip code or neighborhood level? Because in the chart, you'll see mortality rates by different race ethnicity groups across the whole city, and you see some of the disparities and key drivers of mortality. We also have that data by public for preterm birth. What we don't have as easy access to, but like the data exists, including in our systems and elsewhere, is how that breaks out by zip code. So when we've tried to dive into that, we find fascinating things like that piece I mentioned around preterm birth in a certain zip code. Like you can quantify 12 additional preterm births that led to the entire disparity. Those are the things we wanted to think about more, but our infrastructure data reporting has not been built towards that sort of purpose.
I had to go back to my line. I had, within that particular, I'll be selfish and say, if we could also have it broken down by disability and by age, that would be really useful. Thank you.
I will defer to Susan on what data is available, but we would love as much stratification as possible, yes.
Hi, Rocio Molina with the San Francisco Human Services Network. The timeline between now and when decisions are going to be made in potentially January is going to probably go by really rapidly. Do you anticipate that we'll have an opportunity as CBOs to maybe expand on the data that you all have? Want to maybe narrow down the potential pool of or programs that will be facing cuts?
Yeah, and I think, by the way, there is, I wish we had like 18 months to go through this sort of very thoughtful exercise. So I think there's an email address that's being thrown up at the end of this. What we're hoping is, even if you look at outcomes for data, our team said, well, I bet a lot of the CBOs have data that we've never even looked at. So part of what we want is to encourage folks if you're running a program and you have data that you think we need to know about, please send that in. We are actually going through that email. This is not like a vacant email address. And it would also say we are trying to look at cost per client served on an annual basis, which is not how we typically looked at our contracts before, but that is relevant for us to take a look at.
Hi, thank you for clarifying that. My name is Michelle Shonago, and I'm with the Native American Health Center. And so I think that often is highlighted, especially in the communities that we serve, that there's very little data on our people. So I would really appreciate the opportunity to be able to supply that data prior to you guys making those decisions.
Please, thank you.
And will you let us know where to submit that?
There'll be, this is not the most structured thing, because we don't have the time to. There's an email address, which is going to be the central point that our team is actually, we are physically reading it. So the ask and the invitation, which we should actually send out via email after this to the entire CBO distribution list, of which there are hundreds of your colleagues around, is data and outcomes, the things you want us to know or really highlight. Please send them to us. We have some things in-house, but that is by no means the overall picture. So this is the general ask. If your programs, if you feel very, very strongly about, which I believe is probably all your programs, if you have data you want us to see, please send that in, and we will be looking at that. The program teams will be able to see that.
Let's go over here first, and then over there.
Hi, Lauren Hall, I'm with DISH and Support Housing Provider Network. I've been trying to, we do some overdose prevention work in supportive housing, and I think some of it is, the data is really hard to capture with the absence of death and looking at there are so many overdoses that are being reversed within that community that are not measured by DPH, they're not easily measured by us. And so how are you thinking about similar to around the Native American health issues, like some of these things are very difficult to track with you, and we don't have access to coroner data very readily. We don't have access to some of the systemic costs that we are helping avoid with the work that we're doing in supportive housing around overdose prevention. So I'm just curious how to partner with you all on that, because I feel like it's more of a conversation than I can just send you something to an email box. And I mean, I'm worried about those programs that feel like they're life-saving, very critical, but maybe are not in line with the DPH's focus now on recovery, right? So how do we kind of have those conversations?
Yeah, by the way, our focus on recovery is not a solution of effects, including overdose prevention. Note. I keep saying it's an and for us. We have a whole range of things, it's an and. And Hillary Clinton is actually the person to talk to about that.
Hi, my name is Fernando Holmes Benitez. I'm the deputy director of Society. It's a question and a comment. Have you guys considered, in terms of the cuts for next fiscal year, doing it in an equitable manner? I was just thinking top of my head. Let's suppose that it's $500 million in, that is contracted out. Those $17 million would be a 3.4% cut, which I think many of us could manage to find alternative funding for that. I'm not sure if that's something that DPH is thinking about. On the other hand, it caught my attention the last thing that you were saying. It looks like this is an opportunity to redesign and revamp the system of care that we have, which I think that we do need to take a look at. I'm going to put an example: HIV services, the Centers of Excellence. It's in 2004 that concept that was so novel. They last 20 years, and you still have the same, more times than not, the same outcome objectives in these contracts that have not changed in 30 years. HIV now is more of a chronic condition. It's not a dead sentence like it was before. I think that our programs are not responsive to that. So my question would be here, is the opportunity for the Department of Public Health and us as community organizations to create things to be responsive to the needs of the communities that we're serving?
Yes. Let me give one caveat though. It's a yes unequivocally. Caveat is just that there are a whole bunch of things that as we look at our programs, to be honest, that we feel like we want to figure out how we improve, separate from any budget piece, like some of our teams looking at contracts, and it's less about whether we're funding things, but how do we know in partnership with our CBOs that this particular thing that we contracted for is the most impactful, or we've had a contract for a while, do we need to pivot it? Again, it's not even separate from budget, just how do we have the dialogue to figure out where the dollars can be used, what do our CBO partners think we could do differently, or they could do differently around that. That often happens sometimes in one-on-one discussions with folks that know their program leads well, but it doesn't always happen consistently or systematically. And so, like, our teams have raised all sorts of ideas around different things. So we have appetites. The caveat I was mentioning is just recognizing the sheer bandwidth of everybody, our team's time, your team, like our partners. But it is our desire to be looking at things of that sort, that even if there's zero budget impact, like, hey, how do we think about giving a little flexibility here or there? We've been doing this. We actually think if we did this instead, it'd be more impactful. Those are discussions we would love to have, because we do want to approach this stuff with great passion and mission, because we all agree this stuff is critical, and we want to approach it with rigor. To the extent there is data, sometimes there won't be the same level of data, given some very upstream things. But how do we constantly push ourselves to look at what's working, where we need to pivot with our CBOs? So I say all this to affirm that piece. On your first comment, I do want to note a hypothesis we have that you all can weigh in on. Probably the easiest thing for us to do, we could all go home, is the 17 million amounts to about a 5% cut on the addressable CBO contract role. We could cut everybody by 5%, just all right home. And not have to like cut individual programs. I think our hypothesis is that that would not be wise, because we already heard from you all, we did a 1.1% copy cost of doing business increase. This is not DPH specific, this is kind of the mayor's office talking about the city. So over the course of 2 years, we can get down to that rate, 2.5%. And even then, we've got programs enabling us saying, if you don't increase tomorrow, we're gonna have to reduce services, reduce scope, et cetera. And so our assumption has been, we have to appropriately fund, there will be always a stretch, our programs, and getting that the budget savings will require making tough decisions about reducing scope versus just asking everybody to absorb a cut that we all ask you to magically figure it out. Some of you will be able to fundraise for, some will not be able to do. So that is that is an assumption we have. Inviting you all to weigh in if that makes sense or not. So I don't know if I'm starting enough, but. See it. Oh, sorry. Dr. T and Ness, go ahead, hands up. Danielle is running. What am I going to fight to?
Sorry, I feel like you gave me an opening mentioning how we, as we kind of explore how to make our programs more efficient and really be in partnership with the city and assessing these cuts and where to go. You know, one conversation that a lot of CBOs are having is becoming, Medi-Cal reimbursable. And it really, what we're finding out is that it's gonna take a lot of administrative ramp up, a lot of building out of like our systems and teams. And with a 1% COD, that means it's an investment from the CBOs in kind of entering that system. You know, long term, what is the plan in kind of supporting that work, since it potentially could benefit everyone involved?
So I think this is worth a much different type of discussion. To the extent there are a range of CBO, it depends on the type of service, what type of building. Where folks think we can help a range of CBOs make a move to be more able to build Medi-Cal. That is a discussion we can have, and we have been thinking about how to use some of the philanthropic dollars that have been raised for system level change, so they're not ongoing operating. So one-time things about getting a set of providers together with somebody that can help build infrastructure, whether that be documentation or billing or whatever the heck it might be, if there's enough appetite for that, I think there are enough funders who have expressed the desire to have the funding go towards things of that sort. Those are very worthwhile discussions to have, and frankly are between not just DPH, but us and HSH and a range of folks thinking about that. And so I think that's an open invitation. If you all see a large enough need, and whether it be on what type of infrastructure capacity building, but if it leads to a more sustainable path being to draw down revenue sources, I think there's some outlets we can think about one-time investments that don't have to come out of operating budgets, but we would take your collective ask and guidance on what that looks like.
Danielle,
Hi. Thank you, Director Stein. So Lance Toma, with San Francisco Community Health Center and with the HIV AIDS Providers Network. So just to tag on to what just was discussed, I think that I would love that to happen, because I feel like that is not about just the 17 million. It's about growing the revenues across our system of care and for our CBOs. And if there are ways we can invest now so that we can see a larger return to our city, I think, especially with CalAIM initiatives that are in place now with ECM and community supports. But what I would ask is about the process. Between now and January, we're going to blink and it's January. And I see that you'll do other community meetings with CBOs, and I thank you for that. But what I would really ask is that you utilize HSN and incorporate HSN, happen has the other networks that are in place that have our ear to the ground, so we know what's going on, we know what works in addition to the data. And if we can be incorporated into your process and making sure that we are in lockstep with you, so that by the time we get to January, we can also say that there was a partnership that we had with DPH, and we are to as much as we can get to a united front. And then my last is with the consortium, so I'm also on the board of the clinic consortium. I do think there are ways that we can be the best healthcare delivery system to your priority together. And I feel like sometimes we sit outside of the DPH system, and we have to get closer together and figure out how we come to solutions.
Yeah, and on the first, thank you, Liz. On the first one, I think as much as we love meeting with 300 people or the 50 or so, I think we would welcome working with Lucille and others if there are clusters of providers who can all get together that can help channel and represent some things, just so we can actually hear a range of perspectives. And so I think it'd be helpful, I mean, for example, so you have a whole bunch of folks, there's the consortium, there's the, I forgot what it's called, the PSH providers around that, but I don't, I think if folks have recommendations for other, coming from the federal government, every single provider has a national trade, like 15 people sitting around the table, and like you've got a huge swath of folks represented, and it's clearly not, I mean, we're totally different at the local level. And so it would be helpful to identify a handful of folks we can get, not to the exclusion of wanting to chat with or have meetings with individual CBOs, but just so we can hear a summary and more perspectives through and have some dialogue where you can communicate with your providers and get a sense of, hey, we can chat with TPH about ABC, so folks have a sense of what's happening. Is there Dr. T, oh, we're going back and forth.
Yeah.
I should, I'm about to be doing the microphone check.
Hi, Erin Sweeney, the Food Medicine Collaborative, just kind of building off of the Medi-Cal conversation. I think one of the challenges that we have seen is despite the efforts to build internal capacity, even establish hubs locally in San Francisco to be able to engage in CalAIM and draw down that state and federal reimbursement, we've seen San Francisco Health Plan not necessarily be as interested in contracting with community-based organizations locally. And I just see that as a piece of the puzzle, and maybe that's specific to the food-based community support, but I imagine it's happening more broadly. And I just think as we have these conversations, it's important that SFHP is also recognizing the opportunity here and wanting to engage with local CBOs and seeing that as part of this bigger picture towards equity.
Yeah, Dr. Tyler Tremere, San Francisco Arts Foundation. I guess my question around data and submitting is specifically around more controversial programs right now. I mean, I think some of our specifically overdose prevention programs collect quite a bit of data that we aren't required to submit. And in fact, over time, we've been told not to submit certain data because it's just not data that DPH asks for or needs, and I've shared kind of offline trends over time. I guess I'm worried about that data actually being beneficial to you right now, but how it might be weaponized in the current environment.
So maybe with that, some of those things, we, again, looking at everybody else and others, we should, on some of these extremely sensitive things that keep like getting into the debate sphere, let's maybe have an offline discussion about we're looking at some of that together on.
Hi, Jen Baez in San Francisco LGBT Community Center. +1 to the Medi-Cal discussion that's happening. We are part of the TAG system of care, so behavioral health. Even if we were to be able to be in a place where we could build Medi-Cal, which is concerns, our youth population would not be able to access services. Right, I'm wondering if there's consideration for those of us that are serving populations. You know, I see that part of what we're looking at is, are you grant eligible, are you Medi-Cal eligible? The vast majority of our young people are homeless or they are marginally housed. Getting the documentation they need to enroll them is just very challenging, if not impossible. And we have a lot of concerns, especially for our trans youth, in terms of gender markers, names, matching documentation, and just the gender dysphoria, the barriers that's presenting, the ways in which that's impacting their mental health to access mental health services. And of our few young people, about 20% that are still living at home with their parents, they're accessing services with us because they're terrified that they can't have their families know. And so if something like an explanation of benefits or just anything arrives at their home, they're potentially being outed because they access mental health services. So for us to build Medi-Cal, it's taking our program from no barrier to extremely high barrier. And we're looking at having some of the most vulnerable in our population no longer be able to access services.
Yeah, and I think those are great points, which is why I think I said at the outset. At least factually, it's important for us to kind of know and recognize, because we are finding programs all over the place, like San Francisco, where we didn't build this, we didn't build. and that we have to fix, because that means we are leaving federal and state revenue on the table. As opposed to very unique situations where individuals who are undocumented, for example, as well. So I think that those are the types of things for certain very upstream interventions that are just not covered by Medicaid, right? Those are the things we want to make sure we can preserve general fund dollars for, versus services that are not like that, that are eligible for Medi-Cal reimbursement, but in a random situation we haven't utilized support like that is very different thing. And so the 572 million, a lot of that over 2 years was just kind of going through a bunch of things saying, you know what, this is Medicaid reimbursable, we need to go get it reimbursed.
Appreciate that. I was just curious, how does DPH determine, because there's multiple programs within the department, I think of the Behavioral Health Services Act and then CHID. How is it determined in terms of those dollars are drawn down for those respective programs for the CBOs? And then also, when can we submit, like you mentioned, we could submit data or outcomes to help support efforts and dollars maybe for like the general funds, like you mentioned, for those kind of prevention services?
One, right after this meeting, you can start sending us things. And two, I don't, Hillary or Susan or Drew, anyone want to talk about the BHSA or some of the chat and PhD? I took that as part of the question. Drew, you want to answer that just globally?
I can attempt. I think the question is regarding how we would take the 17 and then identify particular areas across DPH. And that's part of what we're trying to do, is kind of break out of the silos where in past we had to put in, like in this most recent budget, we had very short notice and we had to kind of marshal resources on a quick basis. Having this extra, since the budget passed, it's 6 months to really think about a structured approach to across DPH, looking at all of our programs and not have it decided on an individual silo or a division basis. I think that's what we're intending to do, and look at it on that data structure side.
Well, how have you previously done that?
A lot of it depends on when the instruction came and the specific instructions from the mayor's office. So last year, as an example, we looked at every revenue source we could potentially maximize, knowing that we didn't want to leave any unreimbursed eligible out from as we did every effort we could to maximize that revenue. And then there was a short term by other services within individual divisions that would also be either being underutilized or spent cases that we had to turn around and
Do you look at contracts and like specific contracts and see or we can get deliverables?
Do you look at that data?
And well, that's part of what we want. With the speed at which I joined in March, so we were partway through the budget process already. So even for the budget rounds, the additional instructions that came after I joined, yeah, I mean, there are 3-day turnarounds. And so there's not much detailed analysis that's going in to find $50 million for 3 days. So the way we did that, just for transparency, is we took the $50 million, we looked at all of the different parts of DPH, and we said, every team will get a percentage-wise allocate out $50 million, ask those teams in 24 hours to pick their best ideas, like the least bad ideas, check them and put them on the table. And then we had a bunch of folks in a room just go through that and weigh very difficult decisions. That's how you do that exercise in 72 hours. Which is why we're trying to have this discussion now. And I'm under no illusions that this is something gonna make the process easy, or that like we're gonna find all the information easily, or like. We have structural things where we don't track and look at outcomes in a structured way enough. But I hope you see that we are trying to have this discussion at least with more thought and engagement with you all way up front, anticipate. We not only know we have 17 million that we already have to hit, but we're most definitely gonna have other numbers coming. And I don't want us to have to do a 72-hour exercise when no one has done any real work. It's just like every program manager has to put 3 ideas on the table, send it up, and then immediately decide and send it over. And that's about as sophisticated as it can get at that time.
So it's 5 o'clock, we're being very mindful. I know, of the time running aspect of it. I think you want to say something?
If I can.
Yes.
Okay, just go a few more minutes then.
Okay, sorry, I'll go fast. Just Hillary Cummins, DPH, behavioral health. Just wanted to comment on specifically the question about BHSA, stands for Behavioral Health Services Act. I know there's a number of folks in the room whose programs are supported by that. At the same time as what you're hearing from us about the overall budget, the state has made numerous changes in required allocation of BHSA dollars, which we're also working through. We are seeing this, as Director Tsai is describing, really as a holistic process, trying to make department and divisional priorities to look at the holistically the impact of these various budgetary pressures and how we thoughtfully and equitably allocate resources, including finding revenue sources, despite some of the challenges that have just been raised with Medi-Cal and Medicaid billing, to really preserve everything that we can and things important to achieving the aims that Director Tsai described.
Any final burning thoughts? Lucille, okay, you get to close it out.
Thank you. You know, I think I would just love to reiterate that as we all kind of take a look at this, we really want to prioritize equity with the data lens. And a lot of the benefit of working with CBOs is that we can more nimbly and quickly respond to the immediate needs in the community. And so that sometimes means that organizations operate really novel, really innovative programs that maybe aren't perfectly reflected in the data, but would be extremely difficult to replicate if lost. So I definitely will be encouraging our members to submit plenty of information to the email, and definitely look forward to continuing this conversation.
Okay, thank you.
All righty, thank you very much. Thank each and every one of you. We really do appreciate everyone taking their time today. And also just really the thoughtfulness that everyone brought today, the questions, the feedback, the suggestions, which we always appreciate when people actually have suggestions, because it does make things a lot easier for us regarding that. And we're going to take all of this feedback and all the suggestions and, look at it all, and we will get back to you. Regarding that aspect of it. And I know people are taking notes. We actually will be sending out the slides as well. So I know the folks will take little notes here and all that stuff. So you will be receiving that as well. So I just want to say right here.
DPH budget idea.
Yeah. So we're really once again, thanks to the DPH team for coming to the start, and I also want to give a big thanks out to our leadership who actually allow us to be able to set this, because we realize how important it is to share this with the community, make it really a shared decision and not just DPH, but everyone coming together, collaborate to do what's right for our community. So thank each and every one of you. We really appreciate you, and we will stay in touch.
Thank you all.
Please take over, yes.
Bye.